Good evening, everyone. I hope everybody is doing fine and all of you are preparing well for your entrance exam. It's already Wednesday, and just 3 days from now, you all will be sitting for your final battle, that is NEET PG exam. So nothing to worry. First of all, apologies. There were technical issues. There are some technical issues related to internet. So because of that, we could not start on time, but I'll make sure that you get something in return for waiting and listening to me. And if you are listening to this video afterwards, you can still pause and go back and see some of the one-liners which I have discussed here. See, my purpose of discussing one-liners is to take you a bit away from the overdose of motivation you have been getting for the past so many days in whatever video you are seeing. So what shall be the content we'll be discussing in this session? So the next 30 minutes, I shall be talking about some small talk, some idhar udhar ka baat, some academic points. Actually, it will be a lot of academic points. I'll be talking about some exam strategies, practical strategies which you can apply in the exam, and there will be no overdose of motivation. So don't worry, you're not going to be flooded with inspirational quotes. I'm not going to use any inspirational quote. I'm not going to show you any of the ye ho jayega, winners do this, winners do that, nothing of that sort. What we'll be talking is only kaam ka baat. So let us begin with the session. So some of you asked me, sir, why 108? See, when I started finding the number of points I wanted to discuss were way more than 100. So I had to edit them out. It were coming somewhere around 106, 107. So then I said to myself, let's go for 108. 108 is considered a lucky number. Irrespective of religious basis, 108, if you look to take up those mala jo hota hai, the one which you use for doing all the japs, it has 108 beads in that. Our ancient sciences say, and science has already proven, that the distance between sun and earth is 108 times the diameter of the sun. And so many yogas, so many acupressure, the Chinese philosophy, they all agree upon 108 being a lucky number. End of the day, entrance exam, howsoever hard you may prepare, you know that luck is going to play a big role. So it is just one small positive side from my bit from my side to give you 108 points, nothing more than this in the number. So let's begin with the discussion. Let's begin the game. I'll be going requires some degree of elaboration. So first of all, the first point, growth of human fetus. Remember, the growth of human fetus is affected by thyroxine, it is affected by insulin, it is affected by glucocorticoids, but it is not affected by growth hormone. So question can ask you, which hormone has least role in deciding fetal growth? The answer will be growth hormone. Moving over to point number 2. Point number 2, what is the age cutoff for adolescent period? Age cutoff for adolescent period is 10 to 19 years. NEET PG, it has been asked 2 times in the past. Early adolescent period is 10 to 13 year, mid adolescent period is 14 to 16 year, and late adolescent period is 17 to 19 year. Why have I discussed it here? Because OPGAI has got it wrong. If you look at OPGAI 9th edition, they have mentioned it as 10 to 20 years, and late adolescent period, they have some of the controversies, some of the relatable points which will keep you engrossed in the video. If you think that, sir, why are we listening to this video? Every minute counts. Yes, every minute counts. But this video will help you in revising, because out of the 108 points I'm discussing, there are more than 80 MCQs already asked in the last 5 years in NEET PG as well as the Central Institute exam. So you are also revising once you are listening to me, and my focus will be gradually shifting to the clinical aspects. So third point, 90% adult head size is increased by what age? 90% adult head size is reached by 2 years of age, right? Fourth point, which anthropological factor correlates with stature? Lean body mass are being asked in the paper, and this is a statement which is mentioned in Nelson, and it has been added in the new edition of GAI. So lean body mass agar good. So it predicts, it is a prognostic factor for adult onset stature. Centimeter, at 4 years it becomes 100 centimeters. So doubling of birth length occurs at 4. What is the first primary tooth to erupt? Whenever I ask this question in my class, or the lower central incisors which are the first primary tooth to erupt, and what is the age during which they erupt? Around 6 months of age. Now a clinical scenario in the child does not have any eruption of tooth. Mother is concerned, my child is having delayed tooth eruption. What advice would you give to the mother can have delayed tooth eruption? Most common cause of delayed tooth eruption is idiopathic. Other than that, you will look for the correctable causes. The common ones include malnutrition, rickets, and hypothyroidism. There is a huge list which you want to, you can do it, but this is important from MCQ point of view. So some of the facts I will be discussing scenarios also, so that you are more confident once you sit in the exam. So height or length of a child. Now it's the hot topic currently, so let's discuss briefly in, some one-liners. At birth, I have told you the height or length is 50 centimeters. At 1 year, it becomes 75 centimeters. At 2 years, it becomes 88 to 90 centimeters. And at 4 years, it becomes 100 centimeters. So I just told you doubling of birth length occurs at 4 years of age. And what is the Week's formula for length or height of a child? Between age 2 to 12 years, height is given by the formula age in years multiplied by 6 plus 77. Keep body mass in your mind before you perform these numerical calculations. That is the ideal height. You have to take the actual height and compare with the height of the child. Now, what is the related point with the important point that we need to discuss here? Definition of short stature. Often we say chota height. What is chota height? Chota height means short stature. There is a proper definition for that. You cannot make the definition of short stature without knowing this percentile or knowing the standard deviation. That is, without a growth chart being there, you cannot make the diagnosis by absolute value. So definition says height for age below third centile. If you have a centile based chart and you plot it, height for age comes below the curve of third centile, that is short stature. Or if you have a standard deviation wala chart, height for age, if it comes below -2 standard deviation, that is called as short stature. So either third centile se niche or below -2 standard deviation, depending upon what graph chart you are using, you define short stature. Now, dwarfism is not same as short stature. If somebody asks you what is dwarfism, severe form of short stature. Still somebody asks you define karo. So height for age below -3 standard deviation is called as dwarfism. Dwarfism is always pathological. Short stature can be physiological or pathological. Whatever lines I am speaking, whatever words I am saying in this video, every word is important. I have curated everything so that you don't get any nonsense thing. In case you are listening to me, I am responsible for every minute of yours. So what is extra that you need to know in this? I hope all of you are understanding and okay with the speed which I am going. So I'm going a bit fast so that I finish it off in the next 30-35 minutes. And you can always ask me queries. I will be more than happy to answer the queries later on once the video goes up in a recorded form. So before we talk about the causes of short stature, controversial thing, upper segment to lower segment ratio. At birth, the upper segment is bigger. What is upper segment? From crown of head to midpoint of pubic symphysis. What is lower segment? From pubic symphysis to sole of foot. In a newborn, upper segment is larger. In you and me, the upper segment is slightly smaller. So what are the ratios? At birth, the ratio is 1.7:1 to 1.9:1. At 3 years, it becomes 1.3:1. At 7 years, it becomes 1.1:1. Please correct it. It is not 1:1 at 7 years. Lot of books, lot of authors say 7 year pe 1:1 ho jata hai, and they give reference of Nelson. I would advise you read Nelson. Nelson 21st edition very clearly says that beyond 7 year, 1:1 ratio is attained. If you look at the other textbooks, including your good old OPGI, as well as the anthropometric textbooks and ICMR papers, you will find that 8 to 10 years is the age when 1:1 ratio is attained. Beyond 7 year is not same as at 7 year. So 8 to 10 year is the correct answer. If you don't get an option, then obviously 7 year would be the better answer. But if you have 8 or 9 mentioned in the option, that would be a better answer for when is upper to lower segment ratio equal, right? And beyond puberty, आप में और मुझ में कितना है? It is 0.9:1 or 1:1.1. Now, why are we discussing this upper segment, lower segment ratios? You will realize the importance as we move to the next point. Point number 10. What are the causes of short stature? Now, all through your life you have read about physiological short stature, pathological short stature, but nobody thought why is physiological physiological, why is pathological pathological, how do you define it? Very simple. It is defined based upon growth velocity. Growth velocity, example, I am sitting in an OPD, a child comes to me with short stature, I measure his height, I write it down. 6 months later, same child comes to me and I again measure his height. I see in 6 months how much the child has gained. Suppose this child has gained 0.5 centimeter in 6 months. And if normal child also gains of same age also gains 0.6 centimeter in 6 months, I would say his growth velocity is normal. So any child who has short stature but now he is growing fine, we call it as physiological short stature, also called as normal variant short stature. If a normal child grows 1 centimeter in 6 months, this child has not grown at all. You will say ek to short stature hai plus the child is not growing also, decreased growth velocity. Decreased growth velocity indicates pathological short stature. NEET PG examiners have a very fond liking for short stature, and that is why I am discussing in details. Other points I will quickly gloss through. So this is the flowchart you are supposed to remember, handmade flowchart I made some days back. If there is growth velocity which is normal, we call it as physiological short stature. There are two varieties, constitutional delay in growth and familial short stature, right? And growth velocity, if it is delayed, we call it as pathological short stature. Pathological short stature, if there is dysmorphism present, it is either syndromic like Down syndrome, Turner syndrome, Prader-Willi syndromes, etc. or some skeletal dysplasia like achondroplasia. You can easily make out. If there is no dysmorphism, you need to rule out three things. Protein energy malnutrition, which is one of the common pathological causes, chronic diseases and IUGR. And then you perform investigation. Remember, hypothyroidism is more common than growth hormone deficiency as endocrinological cause. And for growth hormone deficiency, we do growth hormone provocation test. If the value is less than 10 nanogram per ml, we confirm the diagnosis of growth hormone deficiency. So what are the things that you need to remember in addition to what I just said? Most common cause of short stature is constitutional delay in growth. Most common pathological cause of short stature is nutritional cause. And most common endocrinological cause of short stature is hypothyroidism. All three potential MCQs. So when you look back after this video is done, you will realize I have not discussed actually 108 points. It is 108 multiplied by 3 or 4. But 108 always keeps it, in perspective. Now, if you see in this chart, I have also talked about constitutional delay in growth and familial short stature. I have written CA, BA, HA. Time is too less to elaborate upon that. Just remember, CA stands for chronological age, the actual age of the child. Bone age stands for skeletal age, how much mature the bones are. HA stands for height age, that is the actual height according to age, which will obviously be less. That is why the child is having short stature. In constitutional delay in growth, the chronological age is larger, bone age and height age are less, but they both correlate with each other, as you can see. In familial short stature, chronological age and bone age are correlating with each other, but height age is lagging behind. There is a useful point you can remember. Whenever bone age will be exceeding the height age, the ultimate height, adult height, will always be less because growth plate will fuse early. The bones are maturing early. There is no time for us to make concepts right now, but I'm trying to explain in as little words as possible. You can always ask me later on, or you can think about whatever I have said here. So if I ask you which has a better height in adulthood, familial short stature will not have a better height, constitutional delay in growth will have a better height, because familial short stature may bone age, if you see, it is beyond height age, and so the bones will fuse early, growth utna nahi ho paega. Another important clue, constitutional delay in growth is always associated with history of delayed puberty in the child also, in the parents also. Familial short stature may, there is a family history of short stature but not delayed puberty. If question says delayed puberty, it is a key word for constitutional delay in growth in all clinical scenarios. So this is, these two slides which I'm showing, short stature wala, they are smaller. Don't worry, after the session, live video session is over, I will put up the larger parts in the comments. So you will get it, don't worry about it. So just listen to whatever I'm saying. Next we move to approach to short stature. Now this is very, very important. Ye aapke causes of short stature are there in your notes, I'm quite sure. Lekin approach to short stature may not be there in your notes, and it is the hot topic for your exams. So how do you approach? Remember, we had done upper segment to lower segment ratio. That will come handy. So whenever you have a child with short stature, you will do upper segment to lower segment ratio and see whether it is appropriate for age or not. If it is appropriate for age, suppose 7 year pe, it should be 1.1 ratio 1, or abhi style ka it is 1.1 ratio 1. So it is appropriate for age. Any appropriate for age upper segment lower segment ratio is called as proportionate short stature. Right? Proportionate short stature, what will be the causes? Physiological short stature, malnutrition, chronic illness, growth hormone deficiency. Whereas if it is not appropriate for age, you will call it as disproportionate short stature. In disproportionate short stature, if the upper segment lower segment ratio is more than expected, for example, 7 year pe, it should be 1.1 ratio 1. But in this child with short stature, you find it is 1.5 ratio 1. So it is more than expected, right? You will call it as short-limbed dwarfism. It is also called as infantile body proportion. What are the causes? Hypothyroidism, rickets, Turner syndrome, achondroplasia. You may get clinical question or you may get a one-liner in the entrance exam. It is important not only from NEET PG but also the IIIMS CET coming in May. If upper segment to lower segment ratio is less than expected, you will think of short trunk dwarfism. The causes include hemivertebrae, TB spine, that is Carey spine, mucopolysaccharidosis, mucolipidosis, and spondyloepiphyseal dysplasias. So following this flowchart not only is important in cases but can be asked as one-liner as well. So please, underweight child can be either acute or chronic malnutrition. That is why weight for age is not a very accurate criteria. Wasting indicates only acute malnutrition, and stunting indicates only chronic malnutrition. And if MCQ says both wasting and stunting are present, your diagnosis will be acute on chronic malnutrition. Right? So underweight, weight for age. Wasting, weight for height. Stunting, height for age. Underweight, दोनों में कम होगा, acute chronic में. Wasting, only in acute. Stunting, only in chronic. So these are the points you should remember from exam point of view. Next we move to point number 13, definition of severe acute malnutrition. Now, definition of severe acute malnutrition has been asked many times in NEET PG exam. It has been asked multiple times, so I'll talk about it again. Any one of the following, if they are present, you say the child is having severe acute malnutrition. First, if the child is having severe wasting. What is severe? Wasting tha below -3 standard deviation. If it is below -2, if it is below -3, you call it as severe wasting. Standard deviation score, Z score same hota hai, so don't get confused. So if the child has severe wasting, that is weight for height below -3 standard deviation score or below -3 Z score, or if mid upper arm circumference is below 11.5, or if there is bipedal edema of nutritional origin, you call it as severe acute malnutrition. Any one of these three, if it is present, you call it as SAM. There was an MCQ in NEET PG, also MCQ in AIIMS entrance exam some years back. They said all of the following are used to define SAM except. There were 4 options. One of the option was height for age, and that was the answer. Height for age is a chronic marker. Acute malnutrition mein it has got no rule. Let us move towards Kwashiorkor. Kwashiorkor, also known as maladaptive protein energy malnutrition. What are the things you should know? 4 essential signs. The hallmark sign is edema. If MCQ asks you what is the hallmark, hallmark ek hi hai, edema. It is bilaterally symmetrical pitting edema. Edema is always present in Kwashiorkor. There may be mental changes like apathy. The child is not interested in his surroundings. There will be growth retardation in the child, and there will be muscle wasting. So these are the 4 essential signs for Kwashiorkor. Child may or may not have hair changes. Child may or may not have hepatomegaly, but these 4 features will always be present. So if you get a marker, if you get a photograph, look at this child, which type of malnutrition it looks like. Pot belly, swollen bilateral limbs, edematous child, looks and hair present on the scalp. That is called as Kwashiorkor. Marasmus will have loss of hair being present. Kwashiorkor rarely can also have alopecia, but it will occur from the sides like this. थोड़ा सा यहाँ से side से जाएगा, as you can see in this child. यहाँ से, you know, there are some people, all these Punjabi rap singers, they are very fond of honey sing. They are very fond of just using a razor all over this part. So that kind of loss of hair is a feature of Kwashiorkor. More important is a sign called as hair sign. Hair sign is not easily seen. Normally Kwashiorkor children have very brittle hair, but you may have patches of pigmented and depigmented hair. It may look something like this. So alternate pigmented and depigmented hair is called as flag sign in the child. Kwashiorkor child has a high risk of mortality. Next you have this child. What is this child? Can you see monkey child appearance, wrinkles on the face and severe wasting? This is a marasmic child. Marasmus is also called as adaptive protein energy malnutrition. There are no essential features here, but you should remember that there are some signs. There is loss of subcutaneous fat. Fat is totally gone. Fat-free बच्चे होते हैं. They have a monkey child or old man face. They have baggy pants appearance, asked 2 times in AIIMS entrance exam. And they have a good appetite. Kwashiorkor children have a poor appetite. These children are found to have a very good appetite. Marasmic children have a better outcome than Kwashiorkor. Now coming to management of SAM. Now I'm not writing it here. There is a flow chart. It's a very tricky flow chart. All I want to convey is 2 points that are of consideration. Earlier concept was any SAM child you admit in hospital. Now that concept is gone. Any SAM child comes to you, you look for 4 things. First, you look for severe edema. Severe edema which is spitting and also causing ascites or involvement of the upper torso. यहाँ पर भी edema आ गया है. Severe edema. Or if the child is having poor appetite, not able to eat. Or if the child is having any danger sign. Danger signs you have read in pneumonia. We will read about it again today. And fourth, if the child is having any medical complication. If any one out of these 4 is present, you call it as complicated SAM, admit in hospital and manage. If it is uncomplicated SAM, चारों में से nothing is present, you manage, supervised home care is provided. Repeated home visits will be there, high calorie protein you will give, immunization will be given, supplements will be given, but you will not admit the child. So, and whenever potential MCQ, what duration the child is admitted in hospital in complicated SAM, he is admitted for 6 to 8 weeks. Potential MCQ, minimum 6 week admit रखना है, 1.5 months will be your likely answer if you get a clinical scenario on this. So just relax and just go with the flow. I'm trying to explain as many things as possible here. Then clinical case can be asked on this, and it is a very troublesome thing. Some days back I had made some practice MCQs on this. I discussed everywhere, and unfortunately all of you got it wrong. So I'll be discussing here. Normally in dehydration, if it is no dehydration, you just give ORT. If there is some dehydration, you give WHO ORS, and in severe dehydration, you give IV fluid, right? You know it already, Priya? In SAM, this protocol is not followed. If it is a SAM child, suppose the child is having loose watery stool and you are unable to ascertain what is the degree of dehydration, you have to assume कि some dehydration तो है. But if you are able to find, so some or severe dehydration, both का management same है if there is no shock. So first category, some dehydration or severe dehydration but no hypotension. The management of choice will be Resomal, rehydration solution for malnutrition. A problem is Resomal is not manufactured, so you will make it from WHO ORS. How to make it? Potential MCQ. Very simple. Normally 1 ORS packet is added to 1 liter of water, right? अभी आप ऐसा नहीं करेंगे. What I am explaining is Nelson 21st edition table. So I am putting it in Word. For making Resomal, take 1 packet of ORS, dissolve it in 2 liters of water instead of 1. Okay? Then you add 50 grams sucrose and 45 ml of potassium chloride. Mix it. This is your Resomal. Clear? Easy to remember. You can go back and listen to it again in the recorded section. And कितना देना है? Orally देना है. Oral solution है 5 to 10 ml per kg per hour over 12 hours. So for 12 hours you will keep on giving it. So 5 to 10 ml per kg, then 5 to 10 ml per kg, and so on. However, ऐसा नहीं है कि if you have to जबरदस्ती give it for 12 hours. In case you find that the child is becoming edematous, puffy, tachycardia, tachypnea is happening in the child, always suspect that overhydration is happening, which can happen in SAM child. And so every hourly you need to monitor these patients. That is very, very important. You may get clinical cases based upon that. Another clinical scenario. Child is not accepting orally. Kya karo? Simple. Put a nasogastric tube, give Resomal through nasogastric tube. Now, second scenario is SAM child with dehydration with shock. Now you have to use IV fluids, and the IV fluid here is Ringer lactate in 5% dextrose. Aata nahi hai, you have to specially make it. If that is not available, you can go in for N/2 5% dextrose or even simple Ringer lactate as well. Normally, shock mein what do? We give IV fluid bolus, right? Here we don't give just bolus like that. All SAM children have sodium retention and they are prone to develop fluid overload. So what we do is, even if there is shock, you give 15 ml per kilogram over 1 hour under monitoring. If the child improves, repeat again over 1 hour, 15 ml per kg in the second hour, and then shift to Resomal in the dose which I mentioned. Total correction done, again same, 12 hours mein hi correction karna hai. Scenario. It is given in Nelson, given in Ghai. Child of dehydration with shock was managed with Ringer lactate 15 ml per kg over 1 hour in 5% dextrose. After 1 hour, there was no improvement in the child. What should you suspect? Suspect septic shock and start antibiotics along with inotropic agents. Very, very important. Can be a potential clinical scenario based MCQ. So I've spent some time. We can now rush through. I hope all of you are not getting overwhelmed by whatever I'm saying. I'm trying to make it as simple as possible and as clinical as possible. But facts will be needed for your exams. There can be no clinical cases without facts. Remember this. A lot of people are talking about integrated. Integration is important, but integration kiska karoge? Only when you know the facts, you will be able to integrate them. So don't neglect things. Do them in a clinical perspective whenever you are revising. So moving over to syndromes in SAM on rehabilitation. There are 3 syndromes. Confusing scenarios can be asked in MCQ entrance exam, and often people don't read them properly. I'll tell only the bare minimum you need to know. When you treat a SAM child, there are 3 problems on recovery which can happen. First is nutritional edema. What is nutritional edema? Now, obviously, edema will occur in a child who does not have edema. So, nutritional edema occurs in marasmic child when high calories are given without protein. Only calorie without protein, child develops edema. That is nutritional edema. Marasmic child develops edema when only calories are given without protein. Management, balance between calories and protein, child will be fine. Mild illness. Second scenario, nutritional recovery syndrome. ये उल्टा है. Nutritional recovery syndrome can happen in Kwashiorkor, Marasmus both. Too much of protein, no calories. Child is not, usko khane ko nahi de rahe, but you are giving him whey protein shake 4 times a day. So what will happen? His body will take it as a stress, and there will be hepatosplenomegaly, ascites, gynecomastia, hypertrichosis. There will be lot of hormones getting released, anterior pituitary hormones and cortisol and estrogen hormone, which will cause acute stress state in the child. Treatment, again, balance proteins and calories, reduce the protein content, increase calorie content, balance them out according to guidelines, child will be fine. Third scenario, refeeding syndrome can be life-threatening. Refeeding syndrome is again just like nutritional edema. You give too much of calories very less of protein. So what will happen is sometimes there is depletion of the body immediately goes from catabolic state to anabolic state. Anything happening suddenly is a bad thing to happen. All of us have bad habits, but you cannot try to change it overnight. If you try to change it overnight, body or person will collapse. This is what happens with these children. Too much of calories sometimes causes phosphate, potassium and magnesium depletion. Mainly phosphate depletion is the hallmark. This phosphate depletion along with alterations in sodium level will cause acute illness in the child, edema and altered sensorium, CNS finding, rhabdomyolysis, they all can happen, and life-threatening syndrome it is. IV phosphate you need to give, and management should be on the lines of just balancing calories and proteins. Refeeding syndrome is more common in Western countries of SAM, not in Indian countries, in Indian scenario, because milk based diet हमारे ज़्यादा use होता है. Milk has phosphate. Milk prevents refeeding syndrome to happen, but it can happen in an institutional setting. So these are the three syndromes scenario of Henoch-Schönlein purpura. So hallmark of Henoch-Schönlein purpura is a rash occurring in the child. It is a rash occurring in the child. Next you have tetrad of HSP, can be asked in exam. Skin rash, skin involvement, arthritis or arthralgia, again more than 50% patients. Renal involvement, only 30% cases. GIT involvement, again 50 to 80% cases it can be seen. So 4 organ systems often involved is 25 to 28 degrees Celsius. According to OPGI, ideal is 25 degrees Celsius. Temperature in delivery room is different from temperature in ICU, which is 22 to 26 degrees Celsius. Please don't get them wrong. Many of the students have a tendency to mix them up. I think there is some issue. Yeah, the internet is playing some truant. I apologize, but Geo is not in my hands. So temperature in ICU is 22 to 26 degrees Celsius. Moving over, cutoff for hypoglycemia in newborn. Random whole blood glucose less than 45 milligram per deciliter is taken to be the cutoff for hypoglycemia. So, and then older children, the cutoff for hypoglycemia is 54 milligram per deciliter. So newborn 45, older children 54. Please don't mix them up. Then you have caput succedaneum versus cephal hematoma. There is a small handmade diagram I have made. Remember it fast. Caput succedaneum is a soft tissue swelling, more common. Cephal hematoma, common but not as common as caput. It is actual true bleeding in the subperiosteal region. Caput succedaneum crosses suture line. Superficial है, cross कर जाएगा. Cephal hematoma is limited, does not cross suture line. Caput succedaneum is maximum size at birth, whereas cephal hematoma increase